Hey everybody, I decided to make a video about Sertraline, a very interesting SSRI. So I'm going to talk about some of the similarities, how do you say that word? Similarities between all the SSRIs and specifically about Sertraline. So come join me over on my laptop while I start this presentation. Hey everybody, I think I finally figured out some software to record a PowerPoint slide and actually get my face up here too in the corner. So that's pretty exciting. It's free software. Anyway, hey, I'm talking about Sertraline or Zoloft today, the second most potent SSRI. Now let's see if I can figure out how to advance slides. Maybe I click on it and then advance it. No, do I gotta click over here? There we go. So, as a class, all the SSRIs, selective serotonin reuptake inhibitors, work by increasing serotonin in the synaptic cleft, right? Increasing the extracellular level by limiting reabsorption or reuptake into the presynaptic cell. Okay, so theoretically, increasing serotonin is what brings about the clinical effects as well as the clinical side effects. These SSRIs have varying degrees of selectivity to the other monoamine transporters, with pure SSRIs having only weak affinity to things like norepinephrine and dopamine. But my last video was about paroxetine, and this video is about sertraline, and the reason I picked them is because they're a little different than the other SSRIs. Class side effects. They all have the same side effects, but some of them are worse than others. I mean, as far as different medications are worse. Usually the side effects happen in the first week or two. Nausea, vomiting, diarrhea, headache. Bruxism is teeth grinding, which my dentist mentioned a lot of psychiatric medications cause teeth grinding. Vivid dreams. Changes in appetite, weight gain, weight loss. It's like Vibrate. It makes you a little house pig. All you want to eat is cake every hour, and you gain weight. But for some people, Vibrate doesn't do that. It makes them lose weight. So, you know. Tremors, akathisia, or it can trigger mania if you're bipolar. All the antidepressants can trigger mania. Cause you to get manic, spend all your money in Vegas. Also, the SSRIs can increase bleeding if you're taking a ton of NSAIDs like ibuprofen, and they can mess around with warfarin, so you need to be probably getting INR checks done. Sexual side effects are very common. Men and women, decreased libido, inability to have an orgasm. I mean, can there be a worse side effect on the face of the planet? Who invented these side effects? Erectile dysfunction. So withdrawing from SSRIs can be pretty painful, especially paroxetine and fluvoxamine, because they have the shortest half-lives. So withdrawal kicks in fast, and, you know, for some people, it honestly kicks in when they're taking their dose every day, just because the half-life is so short. So one way to treat that is fluoxetine has such a long half-life, like a week, so you can give them a couple doses of fluoxetine or Prozac, and it will help boost the serotonin so they don't drop the serotonin so fast and have withdrawal side effects. It really feels like your head is spinning, you're dizzy, you feel like crap, muscle aches and fatigue and electric zapping in the brain or shocks in the brain, which is hard to explain, but you know. Antidepressants killed my orgasm. SSRI induced anorgasmia is something you need to assess your clients for. Ask about sexual dysfunction. You might be able to reverse it with 4 to 16 milligrams of cyproheptadine, which, by the way, comes in 4 milligram tablets and may be useful for eating disorders also. It's kind of basically an antihistamine, anticholinergic. Serotonin antagonist. Interesting medication. So sertraline is the second most potent SSRI after paroxetine. I should try to get a link to that video up here if I can figure out how to do that in YouTube. Anyway, I just made a video on paroxetine. Anyway, the only SSRI with affinity for dopamine receptors. How's that for interesting? I had no idea. I just learned that in this last month or so. Cimetidine can increase paroxetine and sertraline concentrations, so be aware of drug interactions. Tramadol can cause serotonin syndrome, theoretically. At least all the pharmacists think so. Sorry, pharmacists, if you're watching this. But I just get warnings all the time when somebody's on tramadol, and I put them on an SSRI because they're doing their job and doing it well, and I appreciate that. Sertraline pharmacokinetics, half-life's around 27 hours. So, a lot longer than paroxetine, if you remember from my last video. Kids or adolescents have a bigger liver than adults to, body size. And so they metabolize this stuff faster. So a lower dose might have a shorter half-life in adolescence. So you might want to think about doing twice daily dosing if the dose is smaller than 200 milligrams. Okay, so it's got some alpha-1 antagonism, at least 10 times greater than other SSRIs, which is weird and interesting, but not that interesting because it doesn't have any clinical effects, such as hypotension or tachycardia. So if it doesn't have clinical effects, who gives a rip? That's my opinion. But I did have a person get hypotensive with sertraline and dizzy and was like kind of passing out almost and falling in their bedroom, which was probably from the alpha-1 antagonism. I guess I took them off sertraline and they were totally fine. Food intake increases sertraline's plasma levels by about 25%. So it's not nearly as much as Vibrad or Latuda, which you got to take with food, but I would still recommend clients take this with food because they're going to get about 25% more of the drug in their plasma levels. It's 98% protein bound. That's interesting. FDA indications: major depressive disorder, OCD, social anxiety, social phobia, PTSD, generalized anxiety, premenstrual dysphoric disorder. Okay, those are FDA indications. Doesn't mean you can't use them for other things like generalized anxiety, which we use all the SSRIs for generalized anxiety disorder. First line, really. I mean, besides clonazepam, a good SSRI is really the go-to. Okay, the action of the drug may increase energy or activation early on and may boost them into a manic episode, by the way. Onset of therapeutic action is usually 2 to 4 weeks. I always have them come back in a month, 4 weeks, but really you shouldn't consider a dosage change until about 6 to 8 weeks because that's about how long it takes to really see the full efficacy of the medication. It may continue to work for years. As a psychiatric nurse practitioner, I try to convince people to stay on this medication for at least 1 year. But I tell them that's not set in stone, and if they're doing great, they can come off of it sooner. But also, it's totally okay to stay on it for the rest of your life, and it's totally safe to do that. You can add other medications to sertraline, some good augmenting combos, which I stole straight out of the Stahl prescriber's guide, which I cited on the next page, the next slide. Anyway, trazodone is great for insomnia. It's my favorite sleep medication, trazodone, and my first video that I made like a couple years ago. So I hope I make more videos than every couple of years. But, bupropion or Wellbutrin is called Welloft when you combine it with Zoloft. Welloft, that's kind of funny. It gives you a little boost of energy, helps people get off the couch. So it's a good combination. Mirtazapine is a good combination with any SSRI. Reboxetine, atomoxetine, although sertraline could theoretically increase atomoxetine's levels. Modafinil for fatigue, sleepiness, and lack of concentration. You need to be assessing for medical comorbidities like obstructive sleep apnea and hypothyroid, but modafinil can be just an add-on for fatigue. or for being, totally lacking concentration, motivation, and energy. You could think about mood stabilizers like Lamictal. Lithium is classic. Atypical antipsychotics or second generation antipsychotics like Abilify, Vraylar, Rexulti are some of my favorites, but I mean any of them. You could use it if you're treating this depressed person, but it's really bipolar depression, then definitely one of those atypical antipsychotics would be useful. And treatment resistant depression, it's very useful. It's one of the main things. As a specialist in psychiatry, I get referrals from primary care where they've tried an antidepressant or two or three, maybe a mood stabilizer, but they haven't been on a second generation antipsychotic like Abilify. And boom, that just takes care of their depression right away for a lot of people. So it's pretty interesting. Classically, people would augment with lithium, boost PAR, or Cytomel, thyroid hormone. I don't think thyroid hormone really works that great, and the literature I was reading most recently said it's maybe good for a month or two, but it doesn't seem to be a long-term solution anyway. So I just haven't had much luck with it. Okay, you definitely got to get Dulkin's Textbook of Child and Adolescent Psychiatry, Kaplan and Sadek's Synopsis of Psychiatry, and the Stahl's Prescriber's Guide. I highly recommend. I use it every day. I also recommend doing the NEI, Neuroscience Education Institute. I hope that's what it stands for. NEI, Master Psychopharmacology class. If you want to really be an expert in this stuff, take their Master Psychopharmacology curriculum. It's pretty great stuff. I loved it. Anyway, hey, Wikipedia is not bad. All the real scientists are using it. And you know what else? All the real scientists are hanging out there. And I get one of my computer science books because I'm studying that on the side. And all they cite is Wikipedia. They don't even, because who else is going to keep up with something as changing as computer science? Or should I say medicine? Okay. So anyway, Wikipedia. There you go. Thanks for watching. Okay, talk to you later. Another video coming out soon. See if I can figure out how to stop recording. Oh, thanks for watching. Subscribe, like, and hopefully I'll make more videos soon. Okay, bye.